Hello and welcome. My name is Wassilios Meissner and I will give you today a glimpse on the new Movement Disorder Society criteria for the diagnosis of MSA. But before I start, I would like to thank Professor Horatio Kaufmann and Dr. Iva Stankovic for sharing the key slides of their recent presentations at the virtual MDS Congress, where the criteria were initially released, and also the slides provided by Dr. Stankovic coming from the MSA study group meeting. Just here are my disclosures. They're totally unrelated to the content I will present today. The criteria, or the last revision, was conducted in 2008, and we had since then the second consensus statement on the diagnosis of multiple system atrophy. These criteria were very useful for the diagnosis, for the guidance of patients, and also for the identification of patients for clinical trials. But over the years, we have become aware of several issues, and one is the low sensitivity in early stages of the disease. So many patients who will then, over the years, have a diagnosis of MSA were not identified with these criteria. And on the other side, patients where the diagnosis of probable MSA was made, and then they were followed for several years. Some of them turned out to have not MSA, but an alternative diagnosis. So on the two ends of the spectrum in early disease, but also sometimes in advanced disease stages, the diagnosis was not totally appropriate with these criteria. And that was the motivation, the main motivation, to convene a new group to revise the criteria. And as you will see here, this is the task force that was mandated by the International Parkinson and Movement Disorder Society, MDS. A lot of people involved, two chairs, Professor Kaufmann, Professor Wenning, were leading this effort. And then you can see here, there were members, expert consultants, a neuropathology support team, and also a junior executive team that has been very instrumental in doing the groundwork, because in the process, there was a Delphi process, what we call Delphi process, where the expert panel received questions and answers and suggestions and had to come to an agreement, and the junior executive team was here really instrumental in that effort. So let's compare a little bit the overall structure of the old and the new criteria. The old criteria were based on, or had three levels of certainty. Definite was the diagnosis based on neuropathological examination, confirmation of the presence of alpha-synuclein bearing aggregates in oligoneurocytes. And then there were two clinical entities, categories, probable MSA and possible MSA. There was a distinction between MSAP patients, or patients showing more of Parkinsonism, and then an MSAC phenotype where cerebral impairment predominated. So when it comes to the definite category, that was preserved, that was maintained in the new criteria. But there's quite a change in a way that we have a new criteria called clinically established MSA. And the idea here is to really move this category as close as possible to a postmortem confirmed, or to the certainty of a postmortem confirmed diagnosis. And then also a category of clinical probable MSA, which we hope will have specificity a little bit better than possible MSA. And on the other side, a new category called possible prodromal MSA, with the idea here to really capture as early as possible patients. Of course, what is expected that probably in that category over the years, with the identification of new biomarkers, imaging biomarkers, but also biofluid biomarkers, there has been quite an interesting research in recent years. Potentially, there will be biomarkers that will help us to identify these patients beyond the clinical criteria I will present in the next minutes. So as I mentioned already, neuropathologically established MSA is exactly the same. What is required is to identify these abundant alpha-synuclein bearing positive glial cytoplasmic inclusions, as you can see here. And these need to be found in regions that are typically involved in the neurodegenerative process in MSA, the striatonigral system, or the olivopontocerebellar structures. So no change when it comes to the confirmed diagnosis. And then, as I mentioned already, is the clinically established MSA diagnosis. The essential feature is a sporadic progressive adult onset disease which is entirely identical compared to the previous diagnosis criteria. And then there are core clinical features: autonomic dysfunction, poorly levodopa responsive Parkinsonism, and or cerebral syndrome. Here again, you can see that the core features of the disease that were also considered in previous diagnosis criteria were maintained. But as you will see also in the following, there are more details about the severity, and the idea is here to increase the specificity as the disease progresses in these patients. There are supportive clinical features, at least two. There are motor features, non-motor features. These are basically the red flag signs that have been identified over the last 10 to 15 years. And I will share with you a slide for the motor and the non-motor supportive features. And then also MRI biomarkers. We have really learned a lot of MRI over the last 20 years. And now the group felt that it would be important to add these biomarkers also to the clinically established MSI criteria, really make sure that we are very, very close to what the post-mortem assessment would tell us. And then, of course, the lack of exclusion criteria, the exclusion criteria, and I will share with you a slide as well. So when it comes to the different core features, autonomic dysfunction, as you can see, is really specified. It is voiding difficulties with post-void urinary residual volume of more than 100 milliliters. We know that as the disease progresses, the bladder usually becomes hypocontractile, hyperactive, and that usually then leads to an increased post-void residual. And that's quite different from other disorders, in particular Parkinson's disease, where you would not expect that kind of residual volume. Urinary urge incontinence, so that's basically the same, but has been part of the previous criteria, and neurogenic orthostatic hypotension with a drop in blood pressure in upright position for more than 20 in systolic blood pressure or 10 in diastolic blood pressure within 3 minutes of standing or head up tilt test. So this is quite similar. It has been, or what has been removed or from compared to the previous criteria is that there's no longer any need to have a drop than more than 30 systolic millimeter mercury or 15 diastolic blood pressure millimeter mercury. Poorly levodopa responsive Parkinsonism, this is now defined as less than 30% improvement on the MDS-UPDRS3 on 1000 milligram L-DOPA for 1 month, if necessary and tolerated. Of course, the tolerance may be an issue, but the idea is really to push the treatment as far as possible to really understand if there is a residual response, or if there's no response, which would really be important for that criteria. Cerebral syndrome, at least two: gait ataxia, limb ataxia, dysarthria, and cerebellar-oculomotor dysfunction. This is quite identical to the previous criteria. The only thing that has changed is that the oculomotor dysfunction has been detailed a bit more and now relies really on clear abnormalities such as a downbeat nystagmus or a gaze nystagmus. So really very clear features compared to the previous ones. The MRI biomarkers, there's no surprise. This is atrophy of the putamen, one region highly involved in the process, and or a signal decrease on iron-sensitive sequences. We have learned over the last 20 years that there is an accumulation of iron in MSA in the putamen, and we have on MRI the possibility to see these iron accumulations, and probably this is even a very early sensitive sign of MSA, and so there's no surprise that that was maintained as one of the abnormalities that would endorse the diagnosis of clinically established MSA. Atrophy would also, if atrophy occurs in the middle cerebellar peduncle, in the pons or in the cerebellum, these are the regions highly involved in the olivopontocerebellar atrophy, then this would also qualify as one biomarker sign for the diagnosis of clinically established MSA. The hot cross bun sign has been included, and also beyond these measurements of volume, increased diffusivity of putamen and the middle cerebral peduncle were also included, and this goes back to research that has been conducted over the last 15 years, where we have seen these abnormalities, in particular in the putamen, in the pons and in the MCP. What are supportive motor features for clinically established and probable MSA? There's no surprise. It's a rapid progression within 3 years of motor onset. It is severe speech impairment within 3 years, severe dysphagia, so swallowing problems, moderate to severe postural instability, could be an anticolis, it could be a camptocormia, it could be postural deformities of the hands or the feet. L-dopa-induced craniocervical dystonia, which is very typical and very different from Parkinson's disease. Indeed, in Parkinson's disease, we can also, we see L-dopa-induced dyskinesias, but the topography is quite different and usually occurs in the limbs, and it is quite untypical to see it in the face. An unexplained Babinski sign, which reflects pyramidal impairment, which is totally untypical for Parkinson's disease. And then the jerky irregular myoclonic tremor. So in MSA patients, as you're aware of, classical rest tremor is quite rare. It's 20 to 30%. And what can be frequently seen is that very, very subtle, jerky, irregular myoclonic tremor. Postural deformities I already mentioned, so they are part of postural instability, and then of course postural deformities. So these are motor features, and these are basically red flag signs that have been identified over the last 15 to 20 years. There are sort of non-motor features for clinically established and probable MSA diagnosis. Stridor, which is a contraction of the vocal cords, especially occurring at night, and giving rise to a specific sound. Maybe I could just try to imitate it, which is very typical and which is very different from snoring and other noises you may hear during bedtime. So this is really an important feature because it is quite typical for MSA. Inspiratory sighs, patient sitting in front during the consultation, having a deep breath, a deep inspiratory sigh like this, which is also absolutely untypical for Parkinson's disease and endorses the diagnosis of an atypical Parkinsonian disorder, in particular MSA. Cold, discolored extremities, Raynaud phenomenon, I've also known for many years now. Erectile dysfunction, especially in men younger than 60 years, and pathological laughter and or crying are supportive non-motor features and have been identified as red flag signs over the last 20 years. The clinically probable MSA category has quite a similar structure. It's a sporadic progressive adult onset disease characterized by, again, the core clinical features, autonomic dysfunction, Parkinsonism, and a cerebellar syndrome. But as you will see later, I have one summary slide that compares a little bit the clinically established and the clinically probable MSA category. The severity of the different symptoms is less pronounced compared to the clinically established criteria. And what is also true is that the number of supportive clinically features mandatory for this diagnostic category is only 1, and there's no need for to show an abnormality on MRI to qualify for a diagnosis of clinically probable MSA. Of course, the exclusion criteria must also be respected. And here are the exclusion criteria. It's a substantial and persistent response to dopaminergic therapy. Of course, sometimes we have patients with an eventual diagnosis of MSA who may have a benefit for many years, but this is quite rare. So that would alert that potentially the diagnosis is not MSA. Unexplained hyposmia or anosmia on olfactory testing. This is important for the differential diagnosis of Parkinson's disease, because in Parkinson's disease, there is usually reduced olfaction, which is in many patients even a very early prodromal symptom, while in MSA and other atypical Parkinsonian syndromes such as PSP, the smell is rather preserved or only slightly reduced. Cognitive changes such as fluctuating attention, alertness, recurrent visual hallucinations, at least early in the disease, and dementia within 3 years are really features that would clearly be incompatible with the diagnosis of MSA and would rather be in line with the diagnosis of dementia with Lewy bodies. Oculomotor abnormalities, so different from those I mentioned, in line with the cerebellar impairment, suggesting of PSP, such as supranuclear gaze palsy or slowing of vertical saccades, also incompatible with the diagnosis of MSA. And then there are brain MRI findings supporting other diagnoses, for example, PSP, where the atrophy is more pronounced in the midbrain, not on the pons, multiple sclerosis, vascular disease, etc. Other neurological disorders that may mimic MSA and that may have specific patterns and features on MRI and that may allow to make the distinction between MSA and these disorders. Here is this summary slide I mentioned. You can see the comparison between the clinically established diagnosis on the left and the clinically probable diagnosis on the right. And what is different is, as I mentioned already, the severity. So for example, when it comes to autonomic dysfunction here, there's a post-wide residual superior of 100 milliliters, while in the clinically probable category, any volume would qualify. So if there's 20, 30, or 40 milliliters left after voiding, that would already be a sign in favor of a diagnosis of clinically probable MSA. When it comes to the neurogenic orthostatic hypertension, so patients usually we take blood pressure in supine position, then the patient stands up and you measure blood pressure every minute. And in the clinically established criteria, it is only a measurement over 3 minutes. And if you have a drop within 3 minutes, that means that you have really severe sympathetic involvement, so severe cardiovascular impairment. While in patients that may qualify for the diagnosis of clinically probable MSA, it is possible to identify this drop over 10 minutes. And we have had a large study of the European MSA study group that include more than 300 MSA patients. There is a substantial number of patients where the blood drop occurs only after 4, 5, 6, 7, or 8 minutes, and that these patients have less impairment of the sympathetic system, but still there is already some impairment. And this has been acknowledged here in this criteria. And this is why patients with a clinically probable MSA diagnosis can have a drop in blood pressure within 10 minutes of standing. Parkinsonism without the requirement of a poor L-DOPA response, and then the cerebellar syndrome, where at least one of the symptoms would need to be present. As I mentioned already, for the supportive clinical features, it's only one is mandatory. And when it comes to the MRI, there's no need to show an abnormality on MRI to qualify for a diagnosis of clinically probable MSA. Beyond these two criteria, beyond these two clinical categories, there has been in the addition of a new category, possible prodromal MSI. The idea is really to try to identify patients as early as possible, even though still at this time, we don't really have the tools to identify very, very early on the patients. But that is somehow an attempt to really provide the roadmap where we should go and what we should do in the next 5 to 10 years to really be able to identify these patients. Here again, it is a sporadic progressive adult onset disease characterized by their essential features. At least one is mandatory. RBD, which is REM sleep behavior disorder. Patients are enacting their dreams, which is rather a symptom typical for synucleinopathies, so disorders where alpha-synuclein aggregates can be found either in neurons in Parkinson's disease, and dementia with Lewy bodies, or in glial cells such as MSA. And then later on, many of these patients evolve towards diagnosis of either Parkinson's disease or dementia with Lewy bodies, which are the more frequent, and a minority of patients also then has a later diagnosis of MSA. This is one symptom that may be that may qualify, one essential feature that may qualify for the diagnosis of possible prodromal MSA. Neurogenic orthostatic hypertension, so this is similar to clinically probable MSA with a drop in blood pressure of either 20 systolic or 10 diastolic within 10 minutes of standing. And then urinary dysfunction, erectile dysfunction, males below age of 60 combined with unexplained voiding difficulties with post-void urinary residual superior to 100 or unexplained urinary urge incontinence. And then beyond this autonomic core, there needs to be either subtle Parkinsonian signs, which are not sufficiently elaborated to qualify for Parkinsonism, or subtle cerebellar signs, which are not sufficiently severe to really clearly indicate a cerebellar syndrome. And then, of course, the exclusion criteria need to be respected as well. I think this is what I wanted to share with you. This is the first glimpse. There will be now a paper submitted by the group in the next few weeks, and the paper should be published by the end of the year in the Movement Disorder Journal with more details about the process, how the group developed the new criteria, what we hope and what the roadmap is. So what should be the next steps to move really forward, especially with this new criteria, the possible prodromal MSA. Thank you very much for your attention, and I'm looking forward to your questions, and I would like to invite now Dr. Turgunkhujaev to join the discussion.
Thank you very much, Dr. Meissner. It was an excellent talk, and this new criteria hopefully will help and resolve most of the questions that we physicians on the places have regarding this quite common but rare, again, this controversial movement disorder. So if you allow me, I will give you questions that we have received from our dear patients and caregivers. So the question one is, why does it seem that MSA is so hard to diagnose?
It depends. It depends on the symptoms. And I think I would say in many patients, at least in the hand of an expert, the diagnosis is quite straightforward and can probably be made. But of course, there are challenging patients, because we have patients with very, very slowly progressive disease where they can, for many years, resemble to Parkinson's disease or sporadic ataxia, and only after almost 10 years there are specific symptoms that then make change of the diagnosis to MSA from Parkinson's disease or sporadic ataxia. So I think it's really the severity of the symptoms, since today most of the clinical criteria, and still the new MDS MSA criteria, are still dominantly driven by clinical symptoms. It is not so easy in patients where there are only relatively mild symptoms in early disease. And I think what is very important is to continue to work on imaging and other biomarkers. I think we have made tremendous progress, especially when it comes to imaging, because beyond our eyes, when we inspect the images from the patient is coming to our outpatient clinic, and we see, we look at the MRI and see how there's potentially that and that abnormality that would qualify for a diagnosis of MSA. We have now very powerful tools in hand that are not really implemented in a clinical routine basis, but especially imaging in the future will, in my opinion, really make the difference. And in particular, MRI volumetric measurements, there has been a study, very interesting study in the past, where based on 3 regions, the putamen, the pons, and the cerebellum, 3 groups of patients having Parkinson's disease, MSA, and progressive supranuclear palsy were really very nicely discriminated just by measuring the volumes. And these volumes or these measurements allowed already to make a diagnosis of MSA in patients where the clinical criteria did not.
Thank you very much for your response. You already covered the second question that we received regarding the key tests that doctors use in diagnosing MSA. So, as you've told, the best way to diagnose MSA today is experts' opinion and doctors' opinion. Of course, we can do MRI to see some neuro imaging markers. So, can we move on to the next question regarding that? Neuroimaging markers? I'm telling about hot cross band sign. It's known that hot cross band sign can also appear in some sorts of spinocerebellar ataxias. So does it mean that in some cases, when we see a typical MSA patient, but we know that there are some SCA3 patients that can also resemble MSA, should we do genetic tests?
I mean, doctors are always using probabilities, and doctors are trying to get as many signs to make the diagnosis confident. And of course, you're totally right. the hot cross-band sign is not specific, and there are patients with spinocerebellar ataxia that may show these abnormalities. But then these patients are usually younger. In many, since these are autonomic dominant disorders, there are usually other family members. So you really need to get the entire picture. You have to look, are there any other family members? What is the age? So is the patient 40 years old when the disease begins, or is he or she 60 or 70, which makes quite a difference. And I think then also if you have the hot cross-band sign and severe autonomic dysfunction, that makes us very confident that the diagnosis is rather MSA. But of course, if at the beginning of the disease, autonomic dysfunction is not very, very prominent, then of course the diagnostic certainty is not 100%. So from our perspective, I think it depends really also on the resources you have available. There are centers that are, for example, in patients with sporadic ataxia, are running genetic testing, at least a panel of the different SCA 1, 2, 3, 6, 17, and potentially also some of the most frequent recessive disorders such as Friedreich ataxia. This is not necessarily practiced in our center, and we usually really look if there's really probability for a genetic disorder. Of course, if we have a patient 30 years old and there is the hot cross-band sign, and we don't have sufficient information about the family, potentially the father or the mother died very early, then we would go for genetic testing, but not if we have a very typical MSA overall probability when it comes to the different signs.
Thank you very much. Thank you very much for your covering response. We have some other questions coming about the subtypes of MSA. So in the new diagnostic criteria, you mainly mentioned that there are some Parkinsonian and cerebellar signs. So the question is asking about, is there any place for other types or subtypes of MSA?
Now we have in the new criteria, we have maintained the two subtypes, MSAP and MSAC, keeping in mind that the subtype can change. So it is really the clinical symptom, the predominance of the clinical symptom at the time of the examination that drives the diagnosis. And I've clearly in mind patients with MSAC who later on developed very, very important, significant rigidity and Parkinsonism, and finally we switched the diagnosis. But this is still very arbitrary and reflects mainly the topography of the process in the brain, either in the striatum or in the oligopontocerebral system. We have discussed if it would be of interest to incorporate a mixed form, or either even consider an autonomic subtype. But finally, when you look at the criteria, autonomic dysfunction is really the core clinical feature, and we found that it would not make sense to add another category.
Thank you very much. The patient is asking, the caregiver is asking, how can we tell whether my loved one has MSA or Lewy body disease? Especially taking into account that there is a lag for 3 years, as far as I understand this question, they might be asking about this lag for 3 years when we have to monitor the patient for possible signs of incoming dementia.
I think the differential diagnosis between MSA and Lewy body dementia is probably the most difficult. And when we go back, for example, to a clinical trial that was conducted almost 15 years ago, the NIPS trial, where riluzole was administered in 400 MSA patients versus placebo, finally, a substantial number of these patients over the time died and came to autopsy and had a diagnosis of Lewy body dementia. Because in Lewy body dementia, we can also see very, very significant autonomic dysfunction. Now, these patients are usually older, rather 70, 75, 80. And really the cognitive impairment is very early on. Visual hallucinations, for example, sleepiness, daytime sleepiness. And here again, it is really important to listen to the patient, the caregiver, what are the symptoms, and then do the periclinical workup, and then based on the probability, decide if the patient has rather MSA or Lewy body dementia. And I think what is really important is the cognitive impairment. We know that in MSA patients that there can be cognitive impairment, but is usually not early on. So this is very important. Early cognitive impairment in older patients is clearly in favor of a diagnosis of Lewy body dementia.
Thank you very much. The next question is, Dr. Meissner, what test do you think is the most reliable or important to help diagnose MSA?
I think today we have most experience with MRI. We still don't know how many MSA patients really have these abnormalities, at least, especially in early disease, because in early disease, MRI can be normal. So this is sometimes in patients where we see patient for the first time, we have suspicion of MSA, we perform MRI, there's no abnormality, symptoms are still subtle, not very prominent, and then we continue to follow the patient, and after 1 year or 1.5 years, we perform again MRI with the idea to see abnormalities that would allow us to make the diagnosis. So I would say that MRI is currently also from a clinical routines perspective, the easiest accessible and the most with the most scientific evidence. But of course, they're very interesting developments, and we have seen this last year that potentially biofluids, either the cerebral spinal fluid or also plasma and serum, so blood, may be a way to help make the diagnosis. And we have seen last year 2 studies where they looked in the cerebrospinal fluid at the different forms of alpha-synuclein. So what I shared with you at the beginning, that the inclusions, the GLI inclusions, are absolutely typical for MSA. And we now that there are differences in the alpha-synuclein species in MSA patients compared to Parkinson's disease. And there are tests in development that allow, based on the analysis of the cerebrospinal fluid, to get different profiles between Parkinson's disease and MSA. So that could be a test in the future that maybe early on already would allow the differential diagnosis between MSA and Parkinson's disease. And the question is always, is it really important to make this very early distinction? I think it is important, especially when it comes to clinical trials. And we have currently, there's a lot of excitement in the field. There are potentially a few clinical trials upcoming within the next few years. And I think it would be important to identify patients as early as possible to really make sure that they have the appropriate diagnosis, and then potentially offer them to participate in clinical treatment trials.
Yeah, thank you very much. The next question does not seem to be quite fitting the topic, but I will voice them. So not much is mentioned about the heart. What kind of heart problems are indicative of MSA?
Of course, what we know is that the cardiovascular autonomic dysfunction is absolutely one of the core symptoms, as I mentioned already. And we know that in patients with MSA, that, for example, the heart rate variability is reduced. And this is something that may also be in the future used as an additional diagnostic test. So the control, the heart itself is probably fine, but the control of the heart through the sympathetic and the parasympathetic fibers is definitely not functioning 100%. And what is also true is that we have some patients, or there are patients that may sometimes die absolutely spontaneously during the night, and we're always wondering what is the underlying mechanism, and it could potentially be that some kind of heart conduction of the heart could be the underlying mechanism, or some kind of respiratory failure. So probably we would need to better understand these underlying processes. But the heart itself is not a problem. It's rather the control of the heart through the nervous system that is altered. And we know, as I mentioned, this especially when it comes to very easy tests where the heart rate variability is reduced.
Yeah, thank you very much. We have several questions left. So, do you think that there will be a need for the fourth criteria once we have a definite biomarker?
Definitely.
Will we revise our criteria?
So I think the reply is already in the question, and I fully agree that this is a process, and if over the next few years we will have new information, especially on these biofluid biomarkers, if they will help us to make an early diagnosis, then definitely we will see a revision.
Well, I'm just looking for the compares. So, well, the question comes from the hub. We already mentioned this for the response for this question, but still I have to voice it. Is there a special type of MRI that we must ask from our doctors for? Is there any special type of MRI to ask for?
It's not a special type of MRI. The oldest studies have used very simple MRI, 1 Tesla. There are also publications using 1.5 or 3 Tesla. So this is what currently, it depends really where you are in the world. And I'm fully aware that in some countries there's no access to MRI. But if you are in Europe or in Northern America, then usually 3 Tesla MRI is available. And based on the 3 Tesla MRI, there are different sequences. One sequence is called T1, so it depends on the magnetic field that is applied. T1 sequences allow you to measure the volume. As I mentioned, there are now even automated algorithms, still not in clinical routine, but this is probably something that will be implemented over the next 5 to 10 years in clinical routine. And then we have other sequences called T2 or T2 weighted images, where we can also see the atrophy in the pons and the cerebellum, the pituitary. We can see the hot cross band sign. So this is particularly the sequence where you would see the hot cross band sign. And then some additional abnormalities that are not part of the criteria, but that may also be helpful in endorsing the suspicion of the diagnosis that can be seen, particularly with these T2 weighted images. And then there's this third sequence, which are the diffusion-weighted images, which is a measure of diffusibility. And here, again, this reflects atrophy, and there have been studies that have shown that we can measure this now in the putamen or in the pons, in the cerebellar peduncles. And that's the third part. And the fourth part are the sequences, what we call the echo gradient sequences, that allow us to visualize the iron deposits. So usually when I prescribe MRI, I put this on the prescription to make sure that the radiologist really understands what I would like to see, because the MRI can be different depending on the question you have. And for example, a patient with a migraine would not necessarily need all these different sequences, and it would be important to prescribe or to detail for the radiologist what the neurologist would like to see.
Thank you very much. So the last question, it seems to me that it is last question. So the symptoms of people with MSA and their number vary and seem to be all over the map. Are there symptoms that you think are more important, more of a telltale sign for MSA? Some typical, as far as I understand, some typical symptoms for caregivers and people to look for.
Yeah, I mean, there are some of the supportive signs that are really strongly in favor of MSA. I mentioned already the stridor, which is important to identify because this has potentially also a consequence in terms of treatment. And it is really important that the doctor tries to find or to understand through the caregiver if the patient has stridor at bedtime. The dyskinesia I mentioned, so patients with MSA, particularly MSA-P, receiving levodopa or other treatments used for Parkinson's disease, who may develop the dyskinesia, the contractions of the face. This is another quite typical sign. And then beyond the stridor, also these deep inspirations. Of course, they're not entirely specific for MSA, but here, if the differential diagnosis would be between Parkinson's disease and MSA, this clearly would rule out Parkinson's disease and would be in favor of MSA. And then, of course, the severity of the urinary disturbances, if you really have a very, very high residual volume and there's no, for example, in male patient, no prostate adenoma or another cause that it can explain the very high residual volume, this is also a very, very strong clinical symptom in favor of MSA.
Right. Thank you very much for your responses and for your lecture. It was really great. I've learned so much. Thank you, and thanks for our audience for giving excellent questions, and for your time, and for organizers. It was fascinating. Yeah. Thank you very much.
Thank you very much as well for